Hi everyone, my name is Jessica Mangan. My presentation today is on peer and lay health work for people experiencing homelessness. And I would just like to acknowledge that I am in Toronto and this land is the traditional territory of many nations, including the Mississaugas of the Credit, which is covered by Treaty 13. Next slide. So I will start by describing the basic concepts before I dive into what my practicum experience was like and my final project. Next slide. So homelessness describes the situation of an individual without stable, safe, permanent, appropriate housing or the means and ability of acquiring it. So this includes the following. Unsheltered, which includes those living on the streets or in places not intended for human inhabitation. Emergency shelters, which includes overnight shelters, and provisionally accommodated, which refers to those whose accommodation is temporary or it lacks security. Next slide. So what is a peer or a lay health worker? A peer refers to a community member who shares similar lived experiences to the community they are working with. For example, homelessness. Lay refers to a community member who has received some sort of training to promote health or to carry out some healthcare service, but is not a healthcare professional. These workers engage in dialogue with clients, answer any questions they have about the clinical service being offered, and help bridge some of the barriers between the clients and the healthcare system. I just want to note that there are various terms used interchangeably in the literature for peer and lay health workers, such as community health worker, health ambassador, outreach worker, and harm reduction worker. Next slide. So my practicum took place at Inner City Health Associates, which is known as ICHA. It's a homeless health organization based in downtown Toronto. Next slide. So I work closely with the CHAMP program, which stands for Community Health Ambassador Program. This involves training peer workers, or they call it health ambassadors, with lived experience of homelessness as leaders in health services delivery and health promotion. They're trained on various topics such as primary care vaccines, COVID-19 and influenza vaccines, harm reduction, smoking cessation, and STI testing and treatment. So they go on site to various shelter locations with nurses, providing clinical services to engage with residents and provide accurate health information. So the graph on the right-hand side illustrates the impact that the CHAMP program had on vaccine rates in different homeless shelters. As you can see, the shelter sites that utilized this program had higher vaccine rates for both the 1 and 2 doses of COVID-19. This is thought to be effective as peer workers share similar lived experiences as the residents, which facilitates building relationships based on trust. This program also helps to reduce barriers that many people experiencing homelessness face, and it grants them access to healthcare services and information as it's actually brought directly to them. Next slide. So this CHAMP program inspired me to conduct a scoping review on what makes an effective peer and lay health worker program in the homeless sector. My primary objective was to understand the context, the setting, community, condition, or disease of peer and lay health worker programs. And my secondary objective was to examine factors that inhibit and enable effective peer and lay health worker programs among people experiencing homelessness. I identified 4,119 records initially through my search, and in the end, I was left with 38 documents that I included in my review. These included studies were published between 1995 and 2023. Next slide. All documents included were focused on interventions for people experiencing homelessness. Other diseases and conditions that were provided interventions for in conjunction to homelessness were veterans, COVID-19, mental illness, drug or alcohol dependence, tuberculosis, diabetes, HIV, hepatitis C, and intimate partner violence. So 4 main inhibitors were identified. The first one is lack of support and clear scope of role. So role confusion contributed to tensions between the existing healthcare provider staff and the peer support workers if their roles were not clearly defined. Reasons for high turnover were noted due to precarious work opportunities, lack of job security, low pay, heavy workload, and feeling undervalued. And participants did not have regular attendance for various reasons, such as unstable living conditions, transportation barriers, substance use, or lack of readiness to fully engage in the program. The third inhibitor identified was safety of the worker. So some peer support workers had prior conflicting relationships with the community they were serving, which risked their safety while performing their job duties. Lastly, mental well-being and maintaining boundaries were identified as inhibitors. Various studies reported that peers had difficulty maintaining boundaries with clients while still being supportive. And peers who had a history of substance abuse and were working to support clients in active addiction did have a risk of relapse, as peers would need to be able to control their emotions and identify any potential triggers for themselves. Next slide, please. And also 4 main enablers were identified in my review. Shared experience was cited as the most important enabler. The peer support worker and their clients were able to have mutual understanding of one another and display empathy towards each other. Due to their shared experiences, the peers viewed clients as equals, and there was no hierarchy in the peer-client relationship. This is closely related to the second enabler of trust and rapport. Peers were often trusted by clients as they knew the best language to discuss various health topics with them, and they were respected by the clients due to their shared experience and similar background of homelessness. The ability to reduce barriers to testing and treatment and being knowledgeable of the disease, such as if it were diabetes, was an important enabler of these peer support programs. Peer support workers were able to extend their support by knowing which resources existed and showing the clients how to access them. The last enabler was flexibility of role. So there were few restrictions on how peers were able to spend time with their clients, so they could tailor their approach specific to each individual client. And the peer workers did not have to work from a specific location. They could meet at clients at locations of their choosing, which increased accessibility to the program. Overall, I'm in support of implementation of peer support work programs. This is just a really brief overview. It's hard to go fully in depth of what it can do in just 7 minutes, but I think they can be highly effective if run correctly, and they provide mutual benefit to both the peer workers and the clients. So thank you all for listening to my presentation, and I'm happy to answer any questions next in the discussion period.